Well, I'm very pleased to be here and tell you about my ongoing study. This study is an effort to make a contribution toward a better understanding of the origins of black-white and socioeconomic position health disparities. You could easily, if you want, substitute American Indian for black in everything I say, except that the disparities involved in the case of the American Indian are even greater, at least on the physical health side. So just to put it in the context of the kinds of efforts that you folks are hoping to become more deeply engaged in the near future. Evidence revealing racial and socioeconomic disparities in health has long been available and it continues to accumulate at a very fast pace. Among those that are now well documented are racial inequities in overall health, all-cause mortality and life expectancy, low birth weight, infant mortality, reproductive health, hypertension, heart disease, diabetes, and an array of other relatively common disorders. Similar disparities are found across socioeconomic position. Now, although race and SES are connected, they're rather closely associated in some cases, prior research has documented substantial health disparities across SES within race and across race within SES. These racial and socioeconomic position disparities in health imply massive impact in terms of unequal suffering and carry with them dramatic social and economic costs. Not surprisingly then, such disparities have been among the highest priorities of the National Institute of Health. Yet, the causes of disparities and the ways they might be eliminated remain poorly understood. It is clear that racial and SES differences in the availability, use, and effectiveness of medical care and in the level of trust in healthcare institutions and physicians are implicated, as are differences in a variety of health behaviors. However, adjustments for these collective differences have left the majority of racial and SES health disparities unexplained. Available evidence points to the conclusion that potentially modifiable social factors play a fundamental role in the racial and SES health disparities, a role that goes substantially beyond their significance for such well-established risk factors as poor nutrition, smoking, sedentary lifestyle, and obesity. Multiple strands of evidence have been accumulating in support of the role of differential stress exposure in the etiology of health disparities, and stress exposure is increasingly emerging as a leading contender as a principal mechanism by which race and low social class are translated into poor health. Despite this, it is contended that the explanatory significance of social stress with respect to health disparities has never been effectively tested because of misclassification in distinguishing the disordered from the well and the inadequate estimation of differences in exposure to social stress. Indeed, I'm going to argue that progress in understanding the origins of health disparities and in evaluating the stress hypothesis have been and continue to be impeded by several problems, the two most important of which are those just alluded to: the problem of outcome misclassification and a failure to adequately address differences in stress exposure. Although I won't have time to adequately justify it, toward the end of this talk, I will suggest that this version of the stress process model offers a highly promising approach for advancing our understanding of the origins of both racial and SES health disparities. By way of background, I'll begin with the problem of misclassification. As the scientific foundation of public health efforts, the goal of epidemiologic research has been to identify factors implicated in the causation of the particular disorder under investigation. However, both racial and SES health disparities involve a substantial array of often overlapping physical, emotional, and substance use disorders, and problems. An assumption underlying much of what is proposed here and much of our study is that the multiplicity or generality of these disparities suggests that the major contributing factors, both risk and protective, are also likely to be quite general in nature. Based on a review of extant animal and human studies, John Castle argued more than 30 years ago that the social environment acts to raise or lower susceptibility to all forms of distress and disorder in general, and that the nature of the particular disorders that occur is determined on other grounds. Despite accumulated evidence in support of Castle's claim, it has had less than a dramatic effect on conventional research practice. Most epidemiologic research still tends to focus on risk and protective factors associated with specific individual disorders or a narrow range of related disorders. This practice results in risk classification error to the extent that 1, the risk factors under investigation have effects on other disorders beyond those considered in the study, and 2, those classified as well have experienced health consequences that are not yet clinically detectable. It is contended that the misclassification of individuals with unmeasured or undetected forms of distress or illness as not disordered is likely to result in underestimation of the health relevance of the social, contextual, and dispositional factors under study. While recognizing the many mental health contributions, the many public health contributions of investigation based on the standard social etiology model, its utility for identifying fundamental determinants of wide-ranging racial and SES health disparities may be limited. This is so because risk and protective factors are typically identified through contrasting the social experiences, social environmental contexts, personal attributes, and to a limited extent, the genetic makeup of those with and without the disorder under investigation. Those not qualifying for the disorder, the clinically defined disorder, including those for whom the disorder has not quite reached a detectable stage, are classified as well, often erroneously. The crucial point is that the most important factors contributing to health disparities may not be linked to a specific disorder or set of disorders to the exclusion of others. The misclassification of individuals with unmeasured or undetected forms of distress or illness as non-disordered is likely, I believe, to have obscured or yielded underestimates of the significance of causally relevant social, contextual, and dispositional factors. Tammy's kept me talking all morning, so I don't have much voice left. Research that avoids such misclassification may well provide a significant forward leap in our understanding of factors other than inequities in health services and differing health behaviors that underlie racial and SES health disparities. Our study seeks to avoid the misclassification problem by simultaneously considering multiple measures of both physical and mental health, including some that are sensitive to the subclinical effects of adversity and other aspects of social experience. Psychiatric and substance use problems are being measured at both clinical and subclinical levels. They are examined both as outcomes and when set within the life course perspective as risk factors for subsequent physical health problems. To estimate lifetime and recent occurrences of drug abuse and dependence, alcohol abuse and dependence, and psychiatric disorders, and disorders of drug abuse and dependence and alcohol abuse and dependence, we employ the Composite International Diagnostic Interview, the CIDI. The CIDI is a comprehensive, fully structured diagnostic interview designed to be administered by lay interviewers that assess disorders as defined in DSM-4. Based on clinical re-interview studies, there are grounds for some confidence in the validity of these resulting estimates. Our measure is highly similar to the instrument used in the National Comorbidity Study Replication and the World Health Organization-sponsored World Mental Health Study, with some innovations that I'll tell you about at the end if there's time. Because of respondent burden and the low anticipated prevalence of some disorders, we do not employ all diagnostic modules used in these larger studies. The modules being included are social phobia, generalized anxiety disorder, panic disorder, post-traumatic stress disorder, depression, dysthymia, attention deficit hyperactivity disorder, childhood conduct disorder, antisocial personality disorder, drug abuse and dependence, and alcohol abuse and dependence. Because there is substantial evidence that subsyndromal elevations in depression and anxiety have significant social and personal consequences, we are employing dimensional measures as well. Our measures of physical health status include the self-report information typically employed on recent illness, on chronic diseases, and on self-rated health. However, our primary measures are allostatic load and cell aging. These biomarkers address the hypothesis of weathering, originally proposed by Geronimus. She argued that, quote, "The stress inherent in living in a race-conscious society that stigmatizes and disadvantages blacks may cause disproportionate physiological deterioration such that a black individual may show the morbidity and mortality typical of a white individual who is significantly older," close quotes. Our faith and our efforts are based on the assumption that allostatic load and cell aging constitute useful summary measures of weathering. Allostatic load refers to the cumulative wear and tear on the body's systems owing to repeated adaptation to stressors, and thus is thought to provide a meaningful description of the long-term biological consequences of chronic stress. Geronimus and colleagues have argued that this measure is conceptually suited for the study of weathering. Quote, "Because the stress response disrupts regulation of various systems throughout the body, for example, the cardiovascular, metabolic, and immune systems, the concept of weathering encompasses multiple systems and includes impacts on them that might not yet register clinically. Similarly, allostatic load is measured across physiological systems and includes subclinical indicators of the body's response to stress, responses that increase the risk of morbidity," close quotes. Allostatic load has been shown to be associated with mortality, to vary across socioeconomic status, to be associated with increased risk for depressive disorder, and to be significantly elevated among African Americans in comparison to the same age whites. In case some are unfamiliar with allostatic load, I'll just mention that two categories of biomarkers are used for such estimates. Primary mediators, involving substances released by the body in response to stress, including norepinephrine, epinephrine, cortisol, glycosylated hemoglobin, DHES, and a secondary set of mediators that are generated from the effects of primary mediators and that include the kinds of thing your doctor measures at your annual physical. As weathering refers basically to premature aging, it may also be captured by measures of cell aging. Telomeres are DNA protein complexes that cap chromosomal ends. They shorten with each replication and shorten with age in all replicating somatic cells that have been examined. As Aviv has noted, mean leukocyte telomere length may be an indicator of biological age. As such, it yields information beyond chronic age about the risk for diseases of aging, diseases that reduce lifespan, such as coronary heart disease and hypertension. Eppel and her colleagues tested the hypothesis that stress impacts health by modulating the rate of cellular aging. They found women with the highest stress level to have, quote, telomeres shorter on average by the equivalent of at least 1 decade of additional aging compared to low-stress women. Because these biomarkers can be taken to represent current health status and thus can be measured as continuous variables, they allow analyses in which temporal order of variables can be established with confidence and provide a means for assessing changes in health status over time. This strategy will allow for the first evaluation of the concordance between cell aging and allostatic load, and over time, the first assessment of the relative predictive efficacy and that of the components that comprise these two approaches for estimating weathering. The misclassification problem can be substantially avoided, I suggest, by evaluating the predictors, both cross-sectionally and over time, of the presence of problematic status on one or more of the psychiatric, substance, and physical health status dimensions simultaneously considered. By this strategy, researchers can distinguish, I believe for the first time ever, those who have some form of significant health problem from those who do not. Importantly, this multidimensional measurement strategy will also allow assessment of the possibility of cultural and socio-demographic variations in the propensity to express the consequences of stress in physical, emotional, or behavioral ways. Testing this possibility may advance our understanding of the well-established but anomalous finding that despite strong evidence predicting elevated mental health and substance use risk among African Americans, lower rather than higher rates of psychiatric and substance disorders are persistently observed. Some of our own recent work provides one illustration of the possible influence of outcome misclassification. This work involves evaluations of the health significance of lifetime exposure to major and potentially traumatic events. Noting the evidence that childhood victimization, parental death, and parental divorce are associated with risks for mental health and substance use problems occurring years and even decades later, we propose that there is a range of severe events that can be measured retrospectively with reasonable accuracy and that singly or in combination may constitute important mental health and substance use risk factors. In these analyses, we considered a count of the number of different events out of a total of 33 such events ever experienced by study participants. This figure is taken from a 2003 article published in Addiction. It displays the relationship between cumulative adversity and drug dependence based on survival analyses, which assures that all major and potentially traumatic events considered occurred prior to the first onset of dependence. The timing of the experiences of major and potentially traumatic events and of the first onset of drug dependence were established through the careful use of life calendars. Within other analyses presented in this paper, the significance of cumulative adversity remained clearly observable with prior psychiatric disorders, attention deficit hyperactivity disorder, and childhood conduct disorder held constant. This and other findings presented in that paper substantially rule out the possibility that the observed adversity-dependence linkage is spurious or arises from state dependence, allowing the conclusion we believe that high levels of lifetime exposure to adversity are causally implicated in the occurrence of drug dependence. It is worth noting that this cumulative adversity-drug dependence relationship has recently been confirmed in a study on American Indians. This next slide presents a figure based on findings recently reported in Drug and Alcohol Dependence by Don Lloyd and myself on cumulative adversity and alcohol dependence. The results look highly similar to those we saw for drug dependence, and in fact, the whole set of findings reported in this paper quite closely correspond to those for drug dependence. While this correspondence supports the generalizability of the stress hypothesis across substance types, it might also be seen as signaling redundant findings. In this connection, it is important to note that the individuals represented in a disordered category across these two analyses are not the same people. Only 18% 67 out of 365 participants who met criteria for drug or alcohol dependency qualified for both on a lifetime basis. Thus, for some individuals, adversity increases risk for drug problems, while for others, it increases the risk for alcohol problems. It does not seem too much of a stretch to suggest that others exposed to high levels of adversity might manifest psychiatric or physical health problems. This point is reinforced by evidence presented in the Archives of General Psychiatry a few years ago on the significance of cumulative adversity for the lifetime occurrence of major depressive disorder and anxiety disorders. This slide presents results in which, using survival analysis, cumulative adversity predicts a lifetime occurrence of depressive or anxiety disorders, along with the results you've already seen on drug dependence. The black line and broken black line are for psychiatric disorder for African Americans and for non-Hispanic whites, respectively. As John Castle contended long ago, environmental experience appears to act to raise or lower susceptibility to all forms of distress and disorder, with the type of disorder that results being determined on other grounds. This alternative outcome hypothesis also raises a question of the extent to which observed comorbidities across physical, psychiatric, and substance disorders may be an artifact of common antecedent risk factors. If there is time at the end of my talk, I'll present some findings that I personally found provocative in relation to this particular question. So the second problem had to do with adequacy of measuring differences in stress exposure. So let me turn to that. For some time, it has been my contention that the stress hypothesis has never been effectively tested because of the health outcome misclassification problem just discussed, and because of a failure to adequately assess differences in stress exposure. There is a huge body of available evidence that leaves little doubt that exposure to social stress increases risk for poor health, whether defined in psychiatric, substance abuse, or physical health terms. However, despite the reliability with which this stress-health linkage has been observed, the magnitude of most observed associations have led to the assumption by many that the contribution of exposure differences toward explaining observed variations in health risk varies from modest to trivial. Checklists of recent life events have long been and remain the dominant means of measuring stress, providing the basis for the vast majority of our knowledge about the health significance of stress exposure. This is so despite the fact that this approach has long been criticized for ignoring other forms of social stress, among other shortcomings. What we have tried to accomplish over the past 15 years or so is to more broadly assess differences in stress exposure by including consideration of several additional sources or dimensions. Although there are aspects of originality in this work, it largely followed from existing evidence on the mental health significance of chronic or enduring stressors, on the relevance for adult mental health of certain specific forms of early trauma, and suggesting that cumulative adversity may have implications for mental health problems other than post-traumatic stress disorder. In addition, several studies had indicated that perceptions of unfair treatment and discrimination represented a dimension of social stress with important mental health and physical health implications. Our effort to achieve a more comprehensive estimate of stress exposure combines use of a 33-item life event checklist with a 36-item measure of chronic stress and a 33-item measure of the lifetime exposure to major and potentially traumatic events that was described a little while ago. A fourth dimension is David Williams' measure of day-to-day discrimination. For analyses within the African American subsample, in our current study, we have added 3 additional measures of exposure to social stressors. These involve efforts to take account of colorism, the evidence that the darker your skin, the more you're discriminated against by whites and by other African Americans. To assess stressful experiences arising from uncertainty and ambiguity associated with the experience of or anticipation of covert forms of discrimination or disrespect, and an effort to assess the occurrence of trauma associated with a racism experience and the PTSD-like consequences that sometimes follow from such experiences. Not only does the use of current events alone, recent events alone, underestimate stress level in general, it appears to yield biased estimates of relative exposure levels across subgroups, including specifically those defined by race and socioeconomic status. This slide presents data taken from a larger table that I published with Bill Avison in 2003. The scores shown have been standardized and thus have a mean of 0 and a standard deviation of 1. Focusing on the contrasts revealed in the top row based only on recent eventful stressors, and the bottom row, where a composite of 4 dimensions of stressors is considered. It is clear that limiting stress measurement to a checklist of recent events significantly overestimates stress exposure among women relative to men. You'll note that both gender contrasts are statistically significant. There's a little star there, but in the opposite direction. Recent events alone showing women to be more highly stressed, the combined measure showing men to be more highly stressed. The checklist measure alone also greatly underestimates stress exposure among African Americans relative to whites, and substantially underestimates stress exposure among persons of lower SES relative to their more advantaged counterparts. When the measurement of stress is expanded to include recent events, chronic stressors, discrimination stress, and the lifetime occurrence of major and potentially traumatic events, the estimated elevation in stress exposure among African Americans relative to whites is 2.6 times greater than when recent life events alone are considered. Importantly, the substantial contribution of differential stress exposure toward explaining race differences in distress is observed even when discrimination stress is not considered. The corresponding comparison for those in the upper and lower SES categories indicated that the total stress score estimated an elevation in exposure in the lower SES category that is more than 280% higher than estimated on the basis of recent events alone. There seems good basis for contending that the bulk of available evidence may have substantially underestimated the contributions of stress exposure to the occurrence of health problems on the one hand, and yielded biased estimates of the contribution of differences in stress exposure to racial and SES disparities in health on the other. Here's an illustration from research on the determinants of depressive symptomatology. Can you see that at all? I hope. You will note that recent life events account for less than 6% of observed variation in depressive symptoms. Model 1, R squared at the bottom, okay, around just at R squares. Okay, less than 7% of observed variation in depressive symptoms with demographic factors controlled, compared to 20% when all stress dimensions are considered. Taking a look at the final equation. More importantly, with respect to the goal of understanding health disparities, recent life events alone explain only about 20% of the race and about 6% of the SES relationship. That is, look at the change in the coefficients in Model 1 to Model 2, compared to 83% and 46% for race and SES when all dimensions of stress are considered. There you'll compare Model 1 with Model 7 in terms of the coefficient for race and for class. You follow? Those of you who are not familiar with this, these are regression slopes And these numbers here tell you the steepness of those slopes. And when you control on stress, just recent events, the change in those coefficients is relatively small. When you consider the full array of different sources of stress, the change in those coefficients is substantial. Okay? In fact, the majority of the race difference in distress is accounted for by differences in stress exposure. So just to repeat that, if you only use recent life events to measure stress, you can explain about 20% of the race difference and about 6% of the SES relationship, compared to 83% and 46% for race and SES respectively when the stress exposure is measured more comprehensively. It is clear that differential exposure to stress is a powerful mediator of the associations of both race and class with depressive symptoms, a result that can only be observed when an array of dimensions of stress exposure are considered. An important point in this regard, and one that I think is not well understood in the field, is that unmeasured differences in stress exposure across race and SES, or gender, or whatever categories you're examining, will masquerade within research findings as differences in vulnerability or adaptational ability. Accordingly, poor measurement of exposure differences tends incorrectly, I believe, to foster conclusions that locate the source of health disparities largely within the skins of the victims. To illustrate, when a health dimension is regressed on a measure of stress exposure across two or more groups, we often observe a difference in the steepness of the slopes. Here's an example from a rather old study of new mothers that I conducted before most of you were born. The outcome variable here is depressive symptoms, and the stress measures their typical life event checklist. Significant slope differences, such as are displayed here, are generally interpreted as reflecting group differences in vulnerability or responsiveness to stress. However, such differences may partially or substantially arise from unmeasured group differences in stress exposure. Of course, how much of such slope differences reflect variations in vulnerability versus exposure differences is a crucial matter for prevention science. Vulnerability differences direct attention to intervention aimed at increasing coping skills, that is, making those folks more like us. That's another way to say that. While the contrary conclusions suggest the need for efforts to reduce level of stress exposure. That intervening to reduce stress exposure may be possible, at least among the young, I'm going to argue in a moment, but fundamentally the argument is against the habit of assuming that shit happens. And yes, shit happens. But shit happens differentially depending on your location in the social system and the subgroups that define really the conditions of life to which you're exposed. And so since they're correlated with such factors, they are potentially modifiable, since they arise from the context of people's lives. Okay, where am I? So that intervening to reduce stress exposure may be possible, at least among the young, suggested by two findings from a study down in Miami of young adults. The first is from a paper evaluating the relationship between one's family type and account of abuse and dependence problems associated with substance use. So we're comparing single-parent families, kids who grew up in single-parent families, with kids who grew up in two-parent families. The figure reveals the substantial elevation in substance problem risk among those from single-parent versus two-parent families. The left-hand comparison reveals a substantial difference in risk when only sex and race are controlled. Friends' substance use and substance use approval are also held constant for the middle set of bars, while stress exposure alone is added to sex and race in the final comparison. Peer substance use and approval and stress exposure separately and independently account for 78% of the elevated risk associated with single-parent families, and together account for essentially 100% of this elevation. It appears that having two parents matters for substance use risk because they afford protection from associations with substance-using peers and protection from exposure to recent events and lifetime major events. We observed highly similar findings in examining the relationship between family type and psychological distress. A second illustrative finding is from an analysis addressed to what is referred to as the Hispanic paradox, the observation that foreign-born Hispanics, contrary to expectation based on SES, acculturation problems, etc., have lower rather than higher rates of health problems, including psychiatric and substance problems. In our study that took place in Miami-Dade County, we were only able to confirm this paradox among the young women participants, and it turned out that much of their advantage with respect to drug dependence risk was accounted for by lower levels of stress exposure. Cultural differences in the supervision of young women appear to be associated with protection from stress exposure. As noted earlier, a principal aim of our current study is to evaluate the utility of a stress process model for explaining health disparities. A dozen years ago, we tested a similar model with a community study conducted in Toronto, Canada. It's going to be hard for you to see this, I'm afraid. Just a few points. First, every element of the stress process model, the stressors, the personal resources, personal attributes, the availability of social support from family and friends, every one of them makes significant independent contributions, holding all the others constant, to the prediction of depressive symptoms. And collectively, they account for a rather impressive 44% of all observed variation in this mental health outcome. Now, remembering that IQ accounts for only 25% of school performance, you can see that this is really a very substantial leg up on understanding the origins of distress. I should never move away from my notes. Finally, the model provides an explanation for substantial portions of differences in risk across social statuses. This is done in Toronto. African Americans are not included here, so we're looking at the other social statuses. Specifically, it accounts for 24% of the gender difference, 98% of the married versus previously married difference, and 91% of the difference observed across socioeconomic status. A pretty powerful model. As I noted earlier, within our current study, we are substantially guided by this elaborated version of the stress process model. It takes into consideration the significance of variations in recent and lifetime exposure, along with the direct mediating and moderating influences of various social resources, life circumstances, and personal attributes. In setting our course for this study, three persistently observed associations appeared to converge. One, the clear disparities in health across race and SES. Two, the compelling evidence, only lightly reviewed here, suggesting the plausibility of a causal linkage between social stress and varying aspects of health. And three, the exposure to substantially elevated levels of social stress that are found among African Americans and persons of low socioeconomic position. As partially reviewed above, considerable evidence has accumulated over the past 2 decades indicating that the task of persistently coping with eventful and chronic stressors can profoundly affect one's health. It is increasingly clear that stress exposure arises out of the context of people's lives, and thus that it is differentially distributed across contexts defined by social statuses, including those of race and SES. Because stress exposure is generated or conditioned by social factors, the possibility of interventions aimed at reducing such exposure should, in our view, command substantially more research attention. Supportive of this position are findings such as those mentioned earlier, and that important portion of the protective significance of family structure and cultural factors in relation to depression and substance use problem is explained by their apparent capacity to reduce levels of stress exposure. Development of effective interventions, however, requires an understanding of the relative significance of different forms and sources of social stress, and for whom various forms are more and less important. One core objective of this study is to identify the forms or aspects of stress exposure that most contribute to premature aging and thus to racial and SES health disparities. Of equal significance is the goal of identifying the effects of contextual, experiential, social, and personal factors and evaluate the extent to which they mediate, buffer, or amplify the health consequences of social stress. So I'll bore you just with the specific aims of this study. They are to evaluate the stress hypothesis and assess the utility of an elaborated stress process model, the one I showed you, for explaining race and socioeconomic position differences in health and changes in health over time, where A, health status is estimated in multiple ways that address the problem of misclassification, B, variations in stress exposure are estimated more comprehensively than in prior research, and C, the direct mediating and moderating effects of an extended array of social and personal coping resources and of contextual and cultural factors are examined in the context of A and B above. Aim 2, to confirm and extend epidemiologic estimates of race and SES differences in the prevalence of health problems variously and collectively defined while addressing the misclassification problem. 3, to evaluate the interrelationships of differing dimensions of health, variously estimated and their risk significance for one another in cross-section and over time. 4, to describe the distribution of each risk factor identified across race, SES, age, and gender, while examining antecedent factors that put individuals and groups at differential risk for acquiring such risks. You have a risk factor, we'll put you at risk for having that risk factor. And 5, to obtain and preserve samples to support subsequent studies to be proposed later this year on gene-environment interactions relating to factors identified to be or hypothesized to be of risk or protective significance. So I very much appreciate the opportunity to go on about our study and some of the background that sort of led us to where we are in this study. So in closing, I'll just take a minute to tell you exactly where we are. As of today, we have 520 completed cases in hand out of the 1,600 target cases that we're going after. We have very promising success rate. We've not yet tried to go back to soft refusals. I don't have any time right now, the refusals. And we're still at 82.5% success rate, which is damn good these days, I want to tell you. We've only had 2 refusals out of these 520 to provide the biomarker data, which occurs the next morning. We ask people to pee in a bottle for 12 hours. We come to their house in the morning. We take 5 vials of blood. We measure their hip and waist and their height and weight, and we take their blood pressure 3 times spaced 2 minutes apart. And only had 2 refusals out of the 520. We have another 6 cases. I just adjudicated one just before I started talking, where we just couldn't get blood out of people. I mean, we stick them and we stick them and we stick them, and they just won't give up their blood. This is usually people with who are larger than you would want anybody to be. So asking people to do these biomarkers appears to have zero impact on cooperation rates. So all the data are expected to be in hand by December of next year. I'll be presenting some preliminary findings on the first about 650 cases at the International Stress Conference in Dublin, Ireland in June. And I'm done. Happy to entertain any questions you might have. Yeah, please.
What are you telling your subjects? I'm wondering if you can account for their willingness to cooperate. Are they getting anything out of the study in terms of not just direct incentives, but learning about the findings in some form that they can easily comprehend, or how are you conveying the purpose of the study in a way that you think makes them willing to participate?
Well, we have this profound belief in it. And the people that come and they get trained to be our interviewers, myself and my colleague, Tony Brown, we train them. Tony's an African American and a person of substantial experience from working at the Research Center at the University of Michigan. And we get them to believe in the study, to absolutely believe that there's a good chance that we're going to discover stuff that was not previously known and stuff that could make a contribution toward diminishing these health disparities. We sampled by drawing randomly 200 block groups from Davidson County, Nashville. We then got a random sample of all households, 7,000 of them. We screened those 7,000 households to find out who lived there between 25 and 65 years of age. We gathered information on their age, their gender, their race, ethnicity, and education. And this became our sampling frame. We then drew random samples such that half were men and half were women, half are black and half are white, and all are between 25 and 65 years of age. We then send to each of these selected individuals a letter describing the study with a study brochure enclosed and information about our website where they can read more extensively if they wish. We then invite them to call us, but really we call them within a day or two after they receive the letter and attempt to make an appointment. And we go out and go over the study with them, and that's our procedure. The real issue is skill on the phone, really.
There's no monetary incentive to them to participate?
Oh yeah, they get $50 for completing the interview and another $50 for coming up with the 5 vials of blood and their pee and allowing us to, grope them to get their hip and waist measurements and their height and weight. So, and we do then send them back a letter indicating their cholesterol, total cholesterol, and HDL cholesterol, and their blood pressure readings, with a comment if they're seriously deviant about whether they should go see a physician. We have lots of other data, but not the kind of data that they can meaningfully interpret. I can barely interpret it myself. I need my colleagues. My ignorance of biology is monumental, I have to tell you. So, yeah, other questions?
So you mentioned the shorter telomere length in the women under stress. What about men? And how much does differences in women responding to stress account for the difference in life expectancy?
Okay, we're really kind of on the cusp here, and that's another reason why stuff that you guys are planning to do is so important. There have been some studies with fairly large samples with telomeres in them, but these studies did not have measures of stress exposure that were even remotely adequate. So when you ask the question about men, I don't know the answer to that, and probably Somebody knows the answer. The Haynes study, the big, huge national study, does have telomeres in it, but they're giving that now. I don't think that's out yet. The EPIL studies that I mentioned, these are small studies. We're talking about 30 women who had high levels of stress, caring for very sick children, you know, with great difficulties, obviously, with women who didn't have that problem. But the thing is so immensely powerful, you know, controlling on real chronological age. The stress group was 10 years older biologically. You think about that for a moment, you know. African Americans are like 7 years older biologically than whites are. We estimate based upon mortality and sickness levels. But this is going to be new data. Lots of this is going to be quite new. But it's kind of an idea whose time has come. You know, you look around and sort of everybody is either doing it or about to do it. So I think there's going to be lots of stuff. We think that our study will remain unique, mainly because we're trying to address this misclassification problem, which I think might be monumental, really. I mean, where's the lever by which we determine what's important and what's not important? It's this case contrast analysis that we rely on so much. You've got diabetes, you don't. What is it that distinguishes those two groups of people? It's the difference that's the lever by which discovery is managed. But if the contrast group is imperfect because they have other disorders, or a psychiatric disorder, or a substance problem, then the contrast is really not working, and it's particularly not working if Castle is right in arguing that social experience and social context matters by raising or lowering risk for all forms of distress and disorder in general. If we're going to fix things, we need to discover ways to fix them that applies not to a single illness or a single disorder, but to what constitutes the health disparities that we're trying to address. So that's different. I think we measure stress better than most people. I'm sure people would argue with me about that. But I've convinced myself of that. Also, we're measuring lifetime psychiatric disorder, as well as current and recent mental health status. We are able to look at the significance of early life problems, childhood conduct disorder, attention deficit hyperactivity disorder, early depression. Those kinds of things become potential risk factors that are almost in none of these other studies. So I think there's a number of things that makes this study special. I hope so. It's my last study. They're saddling up my horse, heading for the, you know, into the dusk. And so I really hope it's as special as I'm imagining it is at the point. Other questions? Yes, sir.
I just want to actually make a comment. The way you frame your study really emphasizes the difference between policy and intervention. We often talk about intervening to solve a particular bad outcome, but you're talking about the solutions that, practically speaking, that your research might lead to are really large policy solutions about addressing problems in the social context and not just identifying this in the behavior of individuals, for example.
Right.
And I like that framing of this, that draws our attention to policy. But I'm wondering, do you see policy implications of this?
Yeah, well, you know, life is filled with regrets. And one of my regrets is that as I've spent my career trying to provide information that's useful to people who are doing the real stuff, who are intervening, who are trying to change people's lives. And I don't do that. And I can't tell you that my research will be so compelling that it will directly point to some new intervention strategy. I really am hoping, though, that we'll learn something about what kinds of stressors matter for whom and how much and under what circumstances that can be very informative. Of course, this one horse I'm riding, which is the one that you raised, is really big stuff, and we've forgotten. How many people ever read William Ryan's Blaming the Victim? Old book. And all the examples are old. their 60s and 70s. We were a lot better, by the way, then than we are now by a mile in training our students and training ourselves to really understand what it means to be black or Indian or whatever as a minority population, as a disadvantaged population, and so on. The book, in its thesis, is really compelling. So we don't want to end up discovering that the real problem with American Indians is they're not like me, which is basically what that's all about. Let's fix them. Maybe we'll teach them to delay gratification better, to keep time better, to be more diligent on the job, as though, in fact, the problem has anything to do with those characteristics. When you don't measure things like stress exposure adequately, unmeasured differences masquerade in our data and in our results as vulnerability differences, and for vulnerability differences, read differences in competence, effectiveness, efficiency, right? It's blaming the victim. So that policy thing will be certainly in the study. But it's not a new finding and it's not a secret, it's just that something we've forgotten, we forget too often.